بسم الله الرحمن الرحيم. السلام عليكم. You can hear me, right? Just in the chat, if you can hear, you can just write, okay, that's... Yes, okay, great, thank you. Bismillah ar-Rahman ar-Rahim. It's now 10. First, I'd like to welcome all of you. I am Ahmed Madi, ICU consultant and director of residency and fellowship program in King Saud Medical City Critical Care Department. Actually, I'd like to welcome all of you, all the anesthesia department, our colleagues and our friends from the cluster 1, from the King Saud Medical City, from Imam Abdurrahman Al Faisal, and from Al-Iman, and from King Salman Hospitals. Special thanks actually to Dr. Safwan as well as Dr. Thamer for encouraging to have this course. As you know, actually all of us now facing the crisis of the COVID-19 worldwide, and alhamdulillah, in Saudi Arabia almost about we controlled, and we didn't reach the peak yet. We are arranging for the peak. I hope we will not have it. One from the major important problem with the surge plan of the COVID-19 is the staffing plan. The staffing plan in the COVID-19 for the cluster 1 expected to have a peak or almost to extend the flatten the curve on top of the peak, all over the peak for the upcoming 2 or 3 weeks. I hope it will pass safely, inshallah. As you know, as anesthesia department, you are the most important and the most connected specialty with the ICU. For that, you will play a major role with us if we have a crisis or if we need staffing to help us as a frontliner. Currently, the surge plan of the cluster, almost we are as done by the leadership of the cluster. We have the first hostel, Imam Abdurrahman Al Faisal. After that, Al-Iman and King Saud Medical City will start to have many patients in our ICUs now. And the last one will be King Salman. What we are doing in the staffing plan, surge plan for the COVID, we trained almost non-ICU physicians to help us, like internal medicine and OB-GYN, EGS, anesthesia, orthopedic, reaching almost now to 200 physicians from the cluster already have the course. But we did a course for them, which is almost have the COVID-19, not in details, plus some basic principles for the ICU critical care, how to treat patients with the critical care. As of anesthesia department and ICU departments, actually, you don't need to have the basics of mechanical ventilation. You don't need to have the basics of blood gases or the basics of the mechanical ventilation, because we expect all of you know about it. So we will focus in the COVID-19 course for anesthesia and ICU physicians. We will focus on the COVID-19 itself, how to deal with the patient of COVID-19. There is 2 big domains for the COVID-19. First one is the clinical management. Second one is the safety, which is a very, very essential in the COVID-19, because as you know, the widespread of the infectious process of the COVID-19 is really, it is so much horrible. So the same importance of the clinical management of the patient with COVID-19, how to protect yourself. We have our protocol for COVID-19 for clinical management. We will focus in this course all over the 2 days on the clinical management, as well as awareness of the protocol we did for the cluster, and the safety in case of procedures, the safety parameters you need to follow, specific precautions, especially with the procedures you are doing, like intubation or like CPR or whatever, in surgical or bronchoscope. We started the course with creating the WhatsApp group for all of you, and I'd like, actually, before I will go to the details of the course, the structure of the course is done by, I am the director of the course. I have 2 co-directors, Dr. Abul Takin. She's a chief consultant in our ICU. She's responsible for the scientific material of the course, and she posted most of the material we have, like video, which is an illustrative material, like videos, like some workshops, some like free online courses from the SCCM and from the infection control. And another co-director with us, Dr. Ahmed Kuhail. Ahmed Kuhail also is a fellow with us in King Saud Medical City. He's the one responsible for all the technical point, like zooming, like arranging, like everything. I have two coordinators actually. I'd like to thank them a lot, Christine and Emiliana. They are handling all administratives of the course. So feel free at any time to contact us in the group or personally for any administrative issue or any scientific or technical issue. Inshallah, we'll try to solve. The course, if we'll go through the course, it will be almost 2 days. I can share now the screen. Now you can see almost the program of the course. It will start all over the 2 days, today and tomorrow, from 10 until 12:30 p.m. Or a.m. we can say 12. We will start with the introduction as we have it now in 10 minutes. Then my colleague and my friend, Dr. Ahmed Shahzad, he's a consultant ICU, will talk about definition, clinical presentation, triaging of the patient with COVID-19. Dr. Tasmia, she's ICU assistant consultant, and she's working as an infection control coordinator in our ICU. Very essential topic. She will talk about PPE, donning and doffing for the PPE. Dr. Waqqas, if you are reading about COVID-19 of almost in all the media nowadays, we have different pathophysiological for the COVID-19 special characteristic rather than a normal or a classic ARDS we know. So we have many pathophysiological explanations and new regarding the coronavirus. Dr. Waqqas, ICU consultant, he will highlight on. Dr. Basim Hawid, ICU consultant, after that he will talk about diagnostic, testing, and severity. What is the process and what is in our protocol actually? It is present in our protocol, the diagnosis, lab investigation, diagnostic radiology, CT, X-rays, and how to assess the severity of the patient of the coronavirus. The first lecture of Dr. Omar Ramadan almost will postpone to tomorrow because he has 2 lectures. So instead of Dr. Omar Ramadan today, Dr. Bashir Abdurrahman is our ICU clinical pharmacist. He will talk about the pharmacotherapy. Pharmacotherapy of COVID-19, there is many drugs related to the antiviral or related to the interleukin 6 or related to the anticoagulation or related to the antibiotics even. So most of the drugs mentioned in the COVID-19, it will be highlighted by Dr. Bashir Abdurrahman, and he will focus on our protocol. Our protocol, it is almost for Ministry of Health protocol. We cannot institutional protocol. So he will focus about the pharmacotherapy of the patient with COVID-19. Second day, inshallah, we'll start tomorrow again by 10 p.m. with Dr. Omar Ramadan. Dr. Omar Ramadan, he ICU consultant also, and he will present 2 parts of one of the very important disease topics of the disease, which is acute hypoxemic respiratory failure, ARDS. ARDS of the patient, it started actually from the early, from ER, from the oxygen therapy, nasal cannula, high flow, non-invasive helmet, intubation, rescue therapy, all respiratory support or respiratory escalation of the patient with COVID-19. So 2 lectures tomorrow will be with Dr. Omar Ramadan for 1 hour. Dr. Muhammad Audat, ICU consultant, we have presenting some of new modalities for managing of the patient who are practicing in the cluster, like plasmapheresis, like convalescent plasma. Dr. Muhammad Audat, he will highlight those novel modalities of the convalescent plasma and the plasmapheresis. I will go through after Dr. Audat what the precautions you need to take, especially during aerosolized procedures. There are some procedures which can generate aerosolizations more infectious for the staff, for the healthcare workers, like intubation, as we have mentioned, like bronchoscope, like even if you take this intubation for OR, what is the precaution you need to do to protect yourself and the staffing around you for during these procedures. Dr. Ibrahim Suleiman, ICU consultant and head of the neuro ICU, he will end the course by the cluster COVID-19 protocol awareness. We have protocol, extensive protocol, including everything from A to Z, and we have some awareness pathways. Dr. Ibrahim will be anesthesia as well as ICU staff, ICU physicians. So both of them, they will. I hope the voice is clear and almost about to finish. So by the end of the course, we will have MCQ. MCQ, it will be 40 questions. We will send you the link after finishing the course by 12:30 p.m. tomorrow. We'll send you the link. It will be open for 1 hour. This link containing 40 MCQs. MSQs touching all the topics we have. So if you did attend the lectures, almost you will find the most of the answer of the MSQ inside the lectures, just to check your engagement during the course and your awareness about the protocol. So we'll end by the ending of the MSQ's assessment. Then the results and the certificate will be released for all of you. And sooner, I hope we will not need to do, but in case we need all of you, your data, and Dr. Safwan, Dr. Thamer will help us with the leadership of the clusters to have you with us in case of the as a frontliner for defeating the COVID-19 patients. I hope we will not reach to this stage. So I finished my introduction, and if you have any queries, I can answer. Just chat in the chat room any queries, or we can proceed for the first speaker. Thank you so much. No. Okay. We have. Yes, but should sound double. Okay. Maybe if you have opening your mics, I did finish. Kindly mute all your mics and keep only one mic unmuted, which is for the speaker, to avoid the noise. Thank you so much. I will proceed for my friend, Dr. Shahzad Ahmad, for the first lecture, Definition, Clinical Precision, and Triaging. Welcome, Dr. Shahzad.
Thank you, Dr. Mahdi. So nice of you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Dr. Mahdi, my voice is clear and screen is clear for you?
Yes, it was. It's okay. Everything is okay.
That's great. Assalamu alaikum wa rahmatullah, dear friends and colleagues. My name is Dr. Shahzad Ahmad. I'm consultant ICU in King Saud Medical City. So I will start my lecture from today. Basically, it constitutes having an introduction of COVID-19. Most of the information probably just a re-information because most of our colleagues know about what is COVID-19. I will go with the epidemiology and modes of transmission in brief, and then we will discuss about the case definition and pathways, that the pathway patient is coming to the emergency room, triaging the patient to pulmo clinic, stable or unstable, symptomatic or asymptomatic, needs isolation, where in the medical wards or isolation rooms or the critical care department, and how we can keep the patients in isolation after confirming the COVID-19 or suspecting the COVID-19. At the end of the session, we all participants will be able to have a brief introduction enumerating the causes of coronavirus. We can know the signs and symptoms of coronavirus and how we can do with the definition of suspected and the confirmed cases of COVID-19. We will discuss the pathways of COVID-19 patients from emergency room to the ICU. We will move from the introduction of coronavirus. Coronavirus, basically, if you see, and everybody knows from the picture, that it belongs from the family which is called Coronaviridae, and the subfamily is Orthocoronavirinae. It has a different spikes over its structures, actually from microscope. So that's why it's named as shaped protein spikes. About the viruses. Viruses are single-stranded, viruses are double-stranded. Viruses are enveloped viruses, and they have non-enveloped viruses as well. As Coronaviridae family is usually belongs to the single-stranded RNA genome, and these are the enveloped viruses with the positive sense. If we go about the epidemiology, coronavirus family itself, it's not new. In different subcontinents of the world and in different periods of the time. We know 2003 when SARS outbreak came, multiple deaths and multiple cases were documented at that time. And these outbreaks was appeared at that time in Saudi Arabia as well. It was in 2003. Then 2012, Middle East Respiratory Syndrome coronavirus outbreak came with a very large numbers of documented cases and mortality was also there. 2015, from the bats, we found the same characteristic appearance of MERS coronaviruses in South Korea as well. In 2018, it was the top we observed during the Hajj and Umrah seasons as well. There was another surge of MERS coronaviruses with the epidemiological link from the camels. 2019 and 20, when this virus came, it was end of December. A pneumonia outbreak was reported in Wuhan city of China. 31st December 2019, when this outbreak was traced, it was having a similar characteristic appearance of the corona family, which was resembling to the SARS coronavirus. At that time, WHO named it as a COVID-19, which is a similar genetic similarity with the SARS-CoV, which appeared in 2003. If you see this slide, it can be graphical, but I am going that we were doing the courses for the non-ICU physicians, and today we are doing the course of ICU physicians to see that how the coronavirus is affecting the world. That's why we all are together here thinking about the epidemiology, preventing us from with the modes of transmissions, how we can prevent ourselves from this deadly virus. Look at the table. 5th April, when we did the first course, the cases was 1 million and mortality around 50,000 people died all over the world. If we go almost after 29 days, which is today is the 4th May 2020, around 3.6 million people have been affected till today and 250,000 people have been died. It is different in different countries of the world, but the number is huge. That's why it's pandemic. It's involving all of the world. Coronavirus people who got infected with COVID-19 got similarity in the acute severe respiratory illness symptoms. Like they were getting dry cough, fever, and shortness of breath, developing into the respiratory failure. Some people reported as having a mild respiratory illness. Some means in thousands and 100,000s. This COVID-19 has a unique pathogenesis. It is affecting as an upper respiratory tract infection can affect lower respiratory tract infection. This virus has 96% similarity, as I told, to a bat coronavirus. It is widely accepted to originate from the bats as well. But still the WHO does not recommend that it's coming from the bats. Still genetic studies needs to be evaluated that from where this virus came. But as a whole, it has been recognized and thought that mostly it has a zoonotic origin. As I told, that it is almost the similarity as having an outbreak in 2003. The Wuhan strain has been identified as a new strain of beta coronavirus group 2B. We know that there are coronaviruses which have been subdivided from group A to group D. So it belongs from group 2B beta coronavirus. Let's discuss about the modes of transmission. The modes of transmission, the primary mode of transmission is very clear. That is our respiratory droplets. Respiratory droplets can have the contact droplets, and it's spreading from person to person. It can have droplets can stay in the air for a short time, but may stable, viable, and contagious on a metal, glass, or plastic surface. That's why we need to disinfect the surfaces when an infected person come across to touch that surfaces. Now, respiratory droplet is very clear that within the distance of 1 meter, when one person is infected and having a respiratory secretions, it can infect the other person. It stays in the air how long? how much particular matter, less than 5 macrometer or more than 5 macrometer, it's the molecule or droplet nuclei, but it has been advised for the healthcare workers to take the precautions of airborne as well. So airborne precautions are being taken by the healthcare workers, and especially when we are handling the patients, like intubating the patient, doing the suction, bronchoscopy, or any procedure in the ICU or outside of the ICU, when the airway is being involved, at that time we need to take care of airborne precautions. I think Dr. Madhi will have a great lecture, I think tomorrow, how to prevent ourselves from the airborne precautions. The third route has been studied. It is only one study, but it has been found the patients are coming with GI manifestations, and 1 or 2 cases of stool analysis were found that COVID-19 was found as a fecal-oral route as well. Let's talk about the incubation period. So with the previous slide, modes of transmission, number 1 is the respiratory droplets, like a closed contact. Number 2, taking care of airborne precautions. And there is a mode of transmission with fecal-oral route. Let's talk about the incubation period. What is incubation period? The period when the person infects with the coronavirus and then manifests symptoms. It's called the incubation period. Usually it has been recognized coming around the 5 days, and most of the times have been observed that from 1 to 14 days is the incubation period. But in a rare time period, it has been observed that patient can manifest respiratory symptoms on the day of 20 till day of 27 as well. Let's talk about the signs and symptoms. Signs and symptoms for COVID-19 are non-specific, and those infected may either be asymptomatic or develop the flu-like symptoms, or acute respiratory signs, symptoms can be there, such as fever, cough, fatigue, shortness of breath, or body aches can be there. Atypical symptoms have been manifested as well, having a GI manifestations like nausea, like vomiting, like diarrhea. So if we go from this picture, the primary symptoms are in front of us. Patient can have a fever, the temperature recorded 100 Fahrenheit or more than higher. Patient can have a symptoms of pneumonia, whether it is symptoms of upper respiratory tract or the lower respiratory tract infections. If we go with the chart of the signs and symptoms, you will see that the fever has been recorded about 88% of the patients coming with the fever, and 67.7% people have a dry cough, while shortness of breath have been monitored in 18.6% of the patients. While there are some other atypical symptoms like muscle pain, sore throat, or headache, even 5%, which is not a big percentage, but have been observed that nausea, vomiting, and diarrhea is an unclear sign and symptoms, atypical sign and symptom, but has been observed that patient could manifest with COVID-19. Even in some cases in the New York, hemoptysis, or it's not hemoptysis, conjunctival congestion with redness in the eyes, which is 0.8%, has been observed with the COVID-19 patients' manifestations. That's why when Dr. Tasmia will talk in her lecture, she will tell that why the goggles are needed. So goggles are needed to protect our eye, because there is a transmission of COVID-19 virus from eyes to the other person. Let's talk about the definition now. The definition of a suspected COVID-19 case and a confirmed COVID-19 case. This definition has been taken from the Ministry of Health guidelines, and this definition was updated on the 2nd April 2020. So there was in March, in February, there was some other definitions which were having with different scoring systems. But since 2nd April 2020, we are applying this definition, how to suspect a COVID-19, and it is defined as with 2 links. One is the clinical presentation and other is the epidemiological link. Clinical presentation, as I discussed, COVID-19 having acute respiratory illness manifestations like fever, mired or by history, cough or shortness of breath, and in the 14 days prior to symptom onset met at least one of the following epidemiological criteria. What is the epidemiological criteria? Either has a history of travel abroad before, say, 7 or 8 months, especially in the Saudi Arabia, or has visited or being a resident of high risk area like Jeddah, Makkah, Medina, Riyadh, Qatif, Dammam. These are the high risk areas of COVID-19 in the kingdom. Are a close physical contact prior to symptom onset with a confirmed COVID-19 case, or the person working in healthcare facility. These are the epidemiological link. If we exclude the history of travel abroad now, because nobody travel abroad since 12 March, especially nobody's coming inside Saudi Arabia. So other three, we need to remember that anybody visiting the high risk areas, close physical contact with a confirmed COVID-19, or working in the hospitals. If any one epidemiological link with this clinical presentation is present, it scores a high and goes to suspect a COVID-19 case definition. The other clinical presentation, the patient, any admitted adult patient with unexplained community-acquired pneumonia or features of having hospital-acquired pneumonia, is being scored as a suspected case of COVID-19. What about the confirmed COVID-19 case? We suspected, we took the sample, and patient is positive with the PCR that he has a case definition plus laboratory confirmation. It is a confirmed COVID-19 case. Definition of closed contact. Closed contact is defined as healthcare associated exposure, including providing direct care for COVID-19 patients, working in the hospitals, visiting patients, or staying in the same close proximity of a COVID-19 patient is defined as close contact. Clinicians must aware of the atypical presentations. Atypical presentations, as well as think about the patients who are immunocompromised, diabetic, post-transplants, renal failure, congestive heart failure. They can have an atypical presentation. And in these atypical presentations, we need to suspect COVID-19. Let's come to the respiratory triage checklist. I think most of the colleagues of ICU, they are aware of the respiratory triage checklist. It is almost the same in the previous slides I told. It is the same form which is provided in the emergency departments, that the patient who is visiting in the ED of the hospital, if there is an exposure risk having an epidemiological link, it scores 3. Then the signs and symptoms like fever scores 1 in pediatric and 2 in adult. Cough, shortness of breath is the same. Only GI manifestations scores in adults 1 score, pediatric no score. So any person who is coming with the epidemiological link, as we discussed, with a clinical presentation of either fever, cough, or shortness of breath, if score is more than 4, we will ask the patient in the triage to perform hand hygiene, wear the mask, and direct the patient to the doctor in the pulmonology clinic. Now, in the next slide, we found that visual triage has been done. Patient is meeting the case definition. If he is not meeting the case definition, it will go to the regular triage system. But if he is meeting the criteria in the definition of suspected COVID-19, then it needs to be evaluated whether he needs any life-saving procedures, like if he's desaturating, his tachypneic, shortness of breath, or hypoxemic, does it need any endotracheal intubation or not? If yes, it will go to the observation or resuscitational area, and the life-saving procedure will be done, bed management will be informed, and it will be for immediate evacuation to the critical care department. If it doesn't need any life-saving procedure, it will go to the pulmonorespiratory clinic, where it will be evaluated for 2 things: whether he is stable or not stable. Stable for what? Stable for home isolation. If his respiratory rate is less than 20, if he is maintaining saturation more than 92%, his chest X-ray is clear, just take the swab, notify the MOH, and patient can be sent for home isolation for 14 days. We will discuss that how many days we have to send for home isolation. If he is not fit for home isolation, bed management will be informed, and he will be directly for direct admission. Now, this is the same pathway, but if we go with the green color, where the 15 minutes have been written, that critical care case suspected COVID-19 has been placed at ER isolation for stabilization, scoring, and assessment. Patient will be stabilized in form of life-saving procedure. Admit the patient to ICU in isolation within 15 minutes. If there is any administrative problem for the admission, medical on call will accompany the patient to ICU and he can begin the admission process if not done in ER. ICU bed must be available for those patients. It must be an isolated room. It must be a negative pressure isolation room, or the isolation room with HEPA filter can be there. There or in the emergency department, wherever the patient is there, we have to collect the 2 nasopharyngeal swabs. COVID-19 sample must be taken. MERS-CoV and H1N1 sample must be taken with the consultant discretion. Call 937, fill out the COVID-19 form, get the Hassan number, and transfer the samples. If samples come positive COVID-19, treat as per COVID-19 criteria. If negative and the other samples are negative, then we will follow the isolation criteria. Let's see the pathway of transferring COVID-19 positive patient. Most of our colleagues from King Salman Hospital, Iman Hospital, and we know even King Saud Medical City, if the patients are positive in the phase 5 or 4, we are going and transferring the patients to Imam Abdurrahman Hospital. So as long as any COVID-19 result come positive, there is an alarm and crisis management nurse must be activated. Once it's activated, we have to prepare in such a way that the medical team or the ICU team will write down the medical report. They will send to the quarantine hospital where the acceptance is most likely accepted. Like in our phases, Imam Abdurrahman Hospital is still accepting the cases of COVID-19 positive. Patient medical report will be written, a HALA system will be activated, the concerned doctor will be contacted through the crisis management nurse and the doctor's team, and then once accepted, the patient will be transferred from one hospital to the hospital where we have to transfer the patient. Confirm transfer acceptance and readiness of the bed to the cluster designated hospital together with the quarantine ambulance and equipment. Crisis management nurse will be taking care of the persons, of the PPEs for all of them, transferring them, and if there is any problem with the patient's PPE, she will solve those problems. And patient will be transferred. Let's come of the duration of isolation precaution pathway. We have now a definition of suspected cases and the confirmed cases. Confirmed cases either can be symptomatic or the asymptomatic. Symptomatic patients, retesting once clinically recovered. If positive, repeat sample every 72 hours. Every 72 hours, till patient get the negative result. And once negative result came, we have to do another sample 24 hours apart to get the 2 negative samples. And then we can send the patient for 14 days home isolation. For asymptomatic patients, once the sample is done, retesting every 72 hours. Once the first sample is negative in designated health facility, another sample will be done 24 hours apart. If both are negative, 14 days at home isolation. If the suspected cases, 2 things can happen. If initially tested with COVID-19 PCR and comes positive, we will treat as above we discussed. And other one, if suspected cases clinically stable or clinically unstable. Clinically stable home isolation or isolation in designated facility may be considered based on assessment by the healthcare team. If clinically unstable, must be admitted to the hospital for isolation for 14 days. Now, this was my last slide of my presentation. But here, just there is a new thing which I have studied yesterday, studied today, but I think released yesterday. That is from the Ministry of Health guidelines. That is a pathway, return to work of healthcare workers who are across met and got infected with COVID-19 patients. So there they have specific criteria. The MOH have taken the criteria from the CDC. They are mentioning how the healthcare worker, if infected or come across with the positive COVID, and now he has symptoms, how he can return to the work. What I have found in details that the healthcare worker, if come across with the COVID-19 patient, now he can be symptomatic, he can be asymptomatic. If asymptomatic and positive COVID-19, he will be retested after 72 hours. If 72 hours after he has a negative, another sample will be done 24 hours apart to get the second negative sample. If it comes negative, he can come back to join his work. If patient was having a positive symptoms, so if positive symptoms are there and he is asymptomatic, he will be isolated till he get clinically stable condition and becomes asymptomatic. And his test will be repeated every 72 hours. Once the sample is negative, another sample will be get 24 hours apart to get the negative. If both are negative, he will be allowed to join the his work, but with the conditions that he must wear the surgical mask all the time in the clinical facility, and he should monitor his symptoms. Though this is a MOH guidelines, it has been released, but still I will say that every hospital, every cluster, every medical city will have their own infection control guidelines. We have to go with our infection control policies and protocols. Just what I informed about this return of work of healthcare worker. It has been taken by the Ministry of Health from CDC to apply all over the hospital. Possibly it will be the same policy all over the kingdom, but we have to follow our local policies as well. Thank you very much. If you have any questions, I can see in the chat and we can answer. And back to Dr. Mahdi.
Thank you, Dr. Shahzad, so much. If you have any question regarding you can just add in the chat room and you can answer. Also, write your questions and your queries in the chat room. So wherever you are in the Zoom or in the YouTube, you can just send your question through the chat room. Look like everything is clear, Dr. Shahzad. Thank you so much.
It means, Dr. Mahdi, two things.
Yes.
They say either everything is clear and everybody got understand, or nothing got understand.
No, I think the first one.
Thank you very much, everybody, and I think we will go with the next lecture, Dr. Mahdi.
But don't rely. I'm basically anesthesia also, so rarely they are commenting and they're asking. They understand everything. I know that.
Okay.
We have question here, Dr. Bashir asking, can I be next speaker? Dr. Tasmiyah. Dr. Tasmiyah, she's the assistant consultant in ICU, and she will present the personal protective equipment, PPE, donning and doffing, one important topic in any infectious disease, especially COVID transmission. So welcome, Dr. Tasmiyah. Thank you, Dr. Shahzad, so much.
Thank you, Dr. Mahdi.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
Assalamu alaikum, everyone. I'm Dr. Tasmiyah and I'm an ICU assistant consultant. And today I will be speaking to you about the personal protective equipment specifically for COVID patients, which are suspected and also confirmed. Are my slides displayed?
Yes, but it is the slideshow, full screen.
Can you just turn the mobile, please?
Yeah, I'll just turn the mobile. Is it okay? Clear?
Yes, yes, it's okay.
Okay. So today I will be talking about the personal protective equipment for suspected and COVID patients. I would like to begin my lecture by just this tribute, which was showing a physician as first stakeholders or as frontline heroes who's kneeling down on the coronavirus trying to hold up the earth. So we as frontline heroes, our safety comes first. We know we are doing a wonderful, being a frontline hero is not easy, but however, by taking precautions, by playing safe, we definitely need to protect ourselves first and then the patients. So today the objectives of my lecture would be how to don the PPE, appropriate PPE, how to perform hand hygiene, utilize the donning and doffing techniques. And with this, I hope we safely and confidently care for the patients confirmed with or under investigation for the COVID-19 patients. Again, it is very important for us to use our PPE wisely. I mean, we need to know what exactly we need to use and when to use, the exact indication of its use, as well as not to misuse the PPE so as to deprive the other healthcare workers of the very valuable resources that we have. So just in brief, how exactly Dr. Shehzad has already spoken about the mechanism of the how it is transferred or the transmission itself. However, the portal of entry here is mainly the inhalation route as well as through the mucous membranes. So how could we break this chain of infection is by doing a proper hand hygiene technique and also by wearing appropriate PPE for reducing or to break the chain of infection. Now, the CDC guidelines as well as WHO mainly recommends the following precautions that you need to take. It is standard precautions, droplet and contact. You need to follow airborne precautions, especially including the eye protection when you're doing aerosol generating procedures. So this is the current recommendation. There's no doubt. WHO has already stated that it is mainly spread by droplets. However, you do have to take care of the aerosol generating, especially in aerosol generating procedures. You also need to follow your airborne precautions. Now, there are certain basic etiquettes that you need to follow. It's very important for you not to touch your eyes, nose, and mouth with your unwashed hands. Not to fiddle with your PPE or your masks or your face protection, especially when you are in the patient clinical area. The other thing is about the cough etiquette. It is as simple, but however, this needs to be followed. This is like covering your mouth and nose with a tissue, especially when you're coughing or sneezing, and disposing of the tissue in the nearest waste receptacle directly after use. And following this, you need to do a proper hand hygiene after having contacted with the respiratory secretions. Now, if you don't have a tissue, you always need to cough onto your elbow and make sure that this is followed by hand hygiene as well. Now, as healthcare providers, it is very important for us to have an N95 fit test. We will facilitate the fit test by we have a fit test station in our ICU, and this is facilitated by our nurses, ICU nurses. So if you are in need of a fit test and you really need to get your fit test for any other size of mask of yours which is not available, then definitely we will try to help you with this assistance. We also have the PAPR, which is powered air purified respirator, which you see on your right. This is a hood. Okay, so it is provided with a filter piece as well as a battery, and this could be used especially when you have failed N95 fit test with almost all sizes that are available, or in case of male doctors or physicians who have appeared. So these are the indications of the powered air purified respirator. Now, this was a circular which was posted by our infection control team in notifying everyone regarding what kind of PPE that you need to use. So at all triage points, as well as the points of entry, you need to put on your mask. And also, especially in the clinical areas, like if you're working in the ICU, if you're assigned bedside, it's very important for you to be wearing your mask. Now, how does this mask protect you? Of course, it is very important for source control, especially if you, because it's difficult for us to identify who's symptomatic and who's not. So this is very important, especially for the source control and to contain secretions. The other PPEs that need to be worn, especially when you are transporting or when you are caring for a suspected or confirmed case of COVID, is you need to wear your face protection or goggles, a surgical mask, okay, especially when you are just encountering a patient or not doing any aerosol generating procedures. You need to wear gloves and you can wear your yellow gown. So these are a set of PPEs which you need to wear, especially when you are encountering a patient of a suspected or a positive COVID case, but not involved in any aerosol generating procedure. Now, for aerosol generating procedures, as already stated, you need to take precautions that you take for an airborne patient. This is, you need to put the patient in a negative pressure room. It is very important for you to put on your N95 respirator if you are fitted, or a PAPR. This is a powered air purified respirator if you are not, and to wear your goggles or face protection, wear gloves, and what is recommended by our infection control department is to put on your surgical gown, especially when you're doing your aerosol generating procedures. It's very important. The blue gown here is important, as the other one, the yellow one, is not fluid resistant, as well as it is not impermeable to any kind of fluid that drops. Also, we have Ebola suits. However, the supply is very, very limited. And this could also be used in case you are going to be doing an aerosol generating procedure or so on for such patients. Now, donning of PPE, it is very important for you to don PPE in an area that is safe. Gather all the PPE items. What is recommended is to have a PPE cart with all the items provided so that you don't have anyone running about for getting the appropriate size and the PPE that you require. All PPE must be donned before you enter the patient area, and you also need to look for any defects or any damages which may be seen in the PPE. Ideally, the negative pressure room should have an anti-room where you have a clean area and you have a dirty area. And the clean area is the area where you will don on your PPE, and the dirty side is where you will doff. So there's no mixing of these two areas. Now, the behavior in PPE, it is also very, very important that you do your hand hygiene prior to caring for your patients. You need to do them at your 5 moments before touching the patient, before any clean or aseptic procedure, after you come in contact with body fluid exposure, after touching the patient, and after you touch the patient surroundings. So these are your 5 moments where you absolutely have to do hand hygiene. Now, donning PPE, as I already stated, you need to prepare for donning PPE. Make sure if you are a female and you have very long hair, you need to tie your hair long hair so that it doesn't come in the way. Facial hair, it needs to be shaved before you put on your respirator, and all jewelry and other items need to be removed. Gadgets like watches, friendship bands, all others need to be removed. So we also need to take precautions, especially to keep away from contaminating your PPE when you are wearing, and avoid readjusting any PPE while you are in the patient care area. Now, as I already stated, donning should always be preceded by hand hygiene. These are the WHO steps or the sequence for doing hand hygiene. So you take a handful of alcohol rub on your palms, and you try to rub them palm to palm, followed by palm to dorsum, as in the sequence, as you can see here. Palm to dorsum, followed by the fingers interlaced. Then you have the back of the fingers, especially across the palm. Then you grasp the web space of the thumb and clean that aspect. Similarly, you repeat it on your other hand. And then you have the forward and backwards with a rotating motion, especially with your fingertips. And last, you have to clean the wrist. But there are certain prerequisites that you have to meet. You need to make sure your nails are cut short, your wrist is exposed, okay? You need to fold onto your sleeves, especially if they are covering until your wrist. So these are some of the prerequisites. Remove all jewelry, any gadgets that you are wearing, and so on. Now the sequence, I will first go through the sequence and then tell you the do's and don'ts, especially with each step. So the most important thing once you do your hand hygiene is to put on your gown. The main purpose of your gown is mainly to avoid any splashes that could be generated at the patient care area, especially with regards to respiratory secretions or blood splashes and so on. So this is the reason why you are going to wear a gown. So the gown, the purpose of the gown must be met. That is, it should cover the entire attire of yours. So it is very important for you to make sure that you also anchor the ties, especially at the nape of the neck as well as the waist area, and your clothing is covered completely. The second thing that you need to wear is, of course, the mask or the respirator. As I already said, if it's just going to be encountering a patient who is suspected COVID or confirmed, you can wear on your surgical mask. Also make sure that the metal end is the top end of the mask, and the other also make sure that the ties are anchored, one at the crown of the head and the other at the nape of the neck, especially below the ear. So this is important. The metal piece is the top or the upper portion of the surgical mask. Also make sure that you don't try to touch the front surface of your surgical mask. You try to mold on the nasal or the metal bridge at the nose to have a seal, and make sure your nose and your mouth is covered, including or extends up to the chin. The third thing that you wear is goggles. Again, the purpose of wearing goggles is to avoid any splashes to your mucous membrane, the eyes, as well as your mouth. So you will wear your goggles. Also make sure that you do not touch the front surface of the goggles, especially when you are in the patient clinical area. And the last thing that you wear is your gloves. So when you wear your gloves, make sure that your cuffs, it should extend beyond the cuffs so that your skin is not exposed. So this was the sequence of wearing your PPE. So this is what you need to do. Remove your personal clothing and items prior to actually donning on your PPE. It is always recommended to have a buddy or an assistant who can help you or see what you are wearing and who can verify what you are wearing and who can correct you at all of these steps. So the very important for you is to make sure that you visually inspect the PPE for any kind of damages, whether your appropriate size is available or whether you need to get any other size. So you need to have a PPE card available at all times. Again, the first time when you wear your gown, make sure that even the back is covered and the ties are anchored and not loose. During the N95 respirator, make sure that your size of the N95 mask is available. The one that you have been fitted for is available. So I would always recommend you to get your N95 fit test done for more than one size, so that in case of non-availability of one size, you could always go for the other size mask which would be available. So it is important for you, again, the metal piece is your nose part or the nose end, and then you will tie your ties. Make sure the first one or the above one lies at the crown of your head and the other one lies at the nape. There should be no hair coming in between your nape of the neck as well as the bands. Also, it is very important, some practice wearing a surgical mask underneath the N95 mask. This is not a recommended practice. In order to have a tight seal, you should just have the N95 mask fitted onto your face. Now, once you put on your N95 mask, it is very important for you to do your seal test. How you do your seal test is you need to mold the nose piece of your N95 mask, okay? And then you try to take a deep breath and then exhale. Keep your hands around your mask to feel if there is any gush of air or any leak of air around your face. So if there is no leak, it means you are fitted for the mask. However, if there is a leak, or if you can feel some air escaping, or if you see your goggles getting fogged, it means your N95 seal is not correct. So you need to adjust your mold your nose piece and adjust the mask in such a way that it could fit you or could give you the best fit. Now, in the patient area, again, you need to resist temptation to adjust the N95 respirator. Now, when you're wearing your surgical mask, it is very important you do not touch the front surface of the mask because this is the contaminated part of the mask. Also, it is important for you not to have the mask dangling on. Make sure that the purpose of it is met. It should cover your nose, your mucous membrane, your mouth, and especially extend up to the chin as shown in the picture below. Also, for the time being now, we're using it. It is just one use. However, there are recommendations for extended use, which would be coming up, and we will keep you updated about this policy once approved. The step 3 of donning, especially the eye protection, if you're wearing goggles, make sure that it doesn't interfere with your N95 mask, and make sure that there is no fogging of your face shield. So this would, again, as I already said, it would indicate the failure of the N95 fit. Also, it is very important to note that if you are wearing your corrective spectacles, this could not be a replacement for your eye protection. You also need to put on your eye protection in addition to your spectacles. However, at the end of the doffing process, you need to disinfect your spectacles later on in case they seem to be contaminated after your doffing. Eye protection, again, do not adjust the eyewear. As you all know that the front surface of the eye protection will be contaminated, so it is important you do not touch on to your front surface of the eye protection. Also ensure the 4th step of donning, as I already stated, make sure that you do not have any kind of skin exposed at the wrist area. You need to make sure that the gloves cover up to or extend up to the cuff. So this is also to be taken care of. So you need to have an assistant, a buddy, who tells you what you need, what you have missed, or who kind of verifies all the PPE that you have worn before you actually get into the patient clinical area. Now the doffing, to prepare for the doffing of the PPE prior to doffing, you need to check for the signs of gross contamination and remove, like if you've had a blood splash or something, you need to remove your gown and look if it has actually spilled onto your clothing and so on. In addition, the doffing process must be performed in a way that prevents contamination to you from your potentially contaminated PPE. Now, the doffing, as I told you, everything has to be removed inside the patient isolation room. So it is very, very important that you remove your gown, your gloves, as well as your face protection inside when you are inside the isolation room, except your N95 mask, which is removed outside. And remember that all of this waste, that's all of your PPEs, they get into the infectious waste or the medical waste container, which is the yellow color bin, covered bin. So all of this, which is all of the waste that is produced or the PPE, everything inside the isolation room to be regarded as infectious waste and to be discarded in the yellow medical waste bin. Now, this is the sequence of removing your PPE. As we all know, the gloves would be the most contaminated one. So the first step would be to remove your gloves. I will tell you as I go step by step as to how you need to remove your gloves. The second, of course, after you remove your gloves, your hands get contaminated. So you need to do your hand hygiene. Then comes the goggles. You need to remove your goggles following this. Also make sure you do not touch the front surface. Just grasp the handles of it at the nape of the neck and try to bend down and remove the face shield. Then comes the gown. Again, this has to be removed very carefully, not just trying to pull apart the gown so that it could generate a splash or contaminate the entire area. You need to gently remove your ties at the nape as well as the waist. Try to fold it inside out, not touching the outside surface because it is already contaminated. Make sure the inside is out and the out is in, and you try to make it into or roll it into a small bundle and put it inside the infectious waste container. The last,
excuse me, 2 minutes, huh?
Yes, doctor. The last thing, of course, is you need to remove your respirator. Again, you need to grasp the bottom part of your respirator and then the top one, making sure you don't contaminate or touch the front surface. So this is about the doffing of the glove. As you see in the first picture, you just have to pinch over the glove and try to remove it. And then you slide your finger into the glove or beneath the glove and remove it in toto. So this should be followed by the hand hygiene. Also, you need to, this is how you remove your goggles, especially you need to bend down, try to move on to a medical waste, infectious waste. Then try to bend down, remove it just by the headbands and discard it. Again, when you're removing your gown, this is the procedure. This is how you remove it. Make sure you do not just tear it open, and then you need to roll it into a bundle. And as for the N95 respirator, as I already stated, you need to grasp the bottom part or the strap and then followed by the upper strap. So all of this during the sequence, in case you actually encounter or you contaminate your hands, or you try to, you feel your hands are contaminated or any part of the body, you need to again do your hand hygiene at following every step of this doffing of the PPE. So with this, I conclude my talk, and the floor is open for questions.
Thank you, Dr. Tasmia. We have a question here, Dr. Tasmia, from
Yes,
my friend, Dr. Ali. He's asking about the home isolation.
yes, doctor.
And he said how we can do home isolations and we have the family there.
Again, home isolation, Dr. Madhi, we have a specific team from the MOH who has been assigned. Like if you are positive, they would come to assess your home if it really meets the standards of home isolation. Like there are certain things that need to be followed. So especially putting on your surgical mask, trying to isolate yourself away from your family members, making sure that especially if you are symptomatic, not to be in contact with them, and so on, and also not sharing utensils, not to share any kind of personal belongings, personal items, trying to clean and disinfect your homes regularly, cleaning the contact surfaces, and so on. And also there must be certain requirements met, especially with the comfort room and so on. So all this assessment is done by the ministry, and if the home really meets the standards of home isolation, it's only then you can home isolate yourself. Otherwise, you really need to be quarantined with the MOH quarantine hotels that we have.
Also, I'd like to add, I think if you cannot do home isolation perfectly at your home, I think the MOH is offering some sort of quarantine, right?
Yes, doctor. Yes, doctor. They have some hotels and they have quarantine places where they are quarantined. They are sent for quarantine, and then they are monitored regularly for symptoms until the incubation period.
There's another two questions about the doffing.
Yes, doctor.
They mentioned in the video, gown is doffed first and face shield and the goggle later.
No, this is not the first. The first thing, as I already stated, is the gloves, because it is the most contaminated part. The second in the doffing sequence is the goggles. The third is the gown.
I can have, because we have queries actually. By the way, these doffing sequences, you have one question highlighting this point in the MSQ, by the way. But I want to highlight that some scenarios of the videos, the staffing wearing double gloves.
Yes, doctor. The double gloves.
Yes.
Yes, Dr. Madhi. The double gloves are especially recommended, especially when you're dealing with cases of Ebola, not for respiratory protection otherwise. However, there is no harm if you really would like to wear a double gloves, you can. Because once you are contaminated, you can just remove your double gloves. You can remove the outer glove, and then at the end, you can remove your inner glove as well. So this is specifically recommended in case of handling patients who are positive for Ebola or for suspected Ebola. But however, our hospital policy does not recommend this, but there is no harm in following the double glove policy.
Yes, maybe this is making an inquiry to think about doffing the gloves first, but the gown first, as Dr. Tasmia said.
Yes, I will just put the sequence in the group. I will just put it in the group again for everyone to just see the sequence, the donning and the doffing sequence.
Thank you. To be answered one question. I think I have another head cover is not there in donning and doffing.
Yes. In the Ebola suit kit, that we are provided, we do have a head covers, we have the booties as well. So you can use the head covers. If not provided, you already need to be wearing a cap. Like if you have our nurses, staff working in isolation already have a cap which they wear for their thing. So you could put on your disposable caps, and then it's almost the same thing. So you just have to remove off your goggles first, and then the cap, not vice versa.
Last question: what is the percentage of risk with full PPE?
I really have no information regarding this. I haven't gone through it, but however, I will just read up about this. There's no other material that I came across which says the risk is so much with wearing complete PPE and so on. However, I think the risk is far more less if you ensure yourself that you have worn all your PPEs and taken all precautions and followed everything as stated, and followed all infection control
Yes.
precautions.
And I'd like to highlight most of the cases of healthcare worker got
Hello?
procedures. Yes, doctor. I like to add to the same context. Most of the healthcare workers got infected in China or Italy. Most of them during the procedure, the sterilized procedure, especially during intubation with viral load, without proper PPE. So proper PPE almost, as Dr. Tasmia said, almost far away to get infected. Kindly review the sequence of donning and doffing. Doctor, are you with us?
Yes, Dr. Mahdi. The sequence, as I already stated, I will just post it in the group for the reference of
please.
everyone.
Great.
So,
Okay.
yes, I will just post it in the group again.
Shoe cover necessary?
Shoe covers, yes, it is necessary to wear shoe covers, especially the Ebola suits do have shoe covers. But even otherwise, it's not really recommended. But if you are provided with the Ebola suits and the shoe covers is already there, you can make use of it rather than just wasting them.
Thank you, Dr. Tasmia, so much.
Yes. I
will go to the next.
policy, as you said, Dr. Mahdi, is different in different institutions. The donning, the doffing. I mean, there are a lot of videos with different views, different opinions, and videos displaying different doffing sequences. However, the current one that we really recommend in our institution is the CDC, and this is our guidance. I mean, we follow this for our donning and doffing sequence.
Okay. Thank you, Dr.
Thank you,
so
Dr. Mahdi.
Thank you. Again, we have Dr. Rashad. Can bird doctor use N95 if Faber not available? No, I think are you still there, Dr. Tasmia?
Yes, Dr. Mahdi.
Bird doctor, doctor with beard, can
Yes.
he have wear 95 if Faber is not available?
No, Dr. Mahdi. If you are, if you have a beard, there's no fit, no N95 fit test, no N95 mask would fit you or would give you the best fit. So in that case, you have to go for a PAPR. And
Yes.
Otherwise you don't handle this aerosol or you don't handle the patient who is for airborne isolation. This is our policy.
We shaved our beard for Corona, actually. Thank you so much, Dr. Tasmia. Sorry, Dr. Waqqas, we took almost 9 minutes from your time. I'd like to present our next speaker, Dr. Waqqas, ICU consultant. A very, very interesting and really, I like the lecture of pathophysiology because it is heavy lectures, but containing most of the theoretical behind the pathophysiology of the COVID. Of course, if you will understand it, you will know well how you will manage and how you will protect yourself after that. Thank you, Dr. Ismail. I can present Dr. Waqqas. You can share your slides.
Assalamu alaikum, everybody. Thank you, Dr. Mahdi, for introduction. I'm Dr. Waqqas, ICU consultant in King Saud Medical City. I hope the slides is clear. And voice is clear. Can we proceed?
Yes,
Hello?
it's clear.
Okay.
Yes, clear.
Okay. First of all, disclaimer about this presentation. This presentation is based on the ideas, interviews, and the articles of Dr. Gattinoni, who is German anesthetist. And so this one to be taken in consideration, but these are not the guidelines. So follow the guidelines, your local guidelines, wherever you are working. So I'll proceed. First of all, this is the most famous slide you'll find everywhere, almost in all the presentation. This is from New England Journal of Medicine. To show the pathophysiology, as you can see, SARS-CoV-2, it has spike proteins and it binds to the ACE2 receptors, and finally it is engulfed, and viral enters, replicates, and it will cause the downregulation of ACE2 receptors. As a result, angiotensin 2 will not find the place to attach, and what will happen, it will be accumulated, and it ultimately will cause acute leg injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. Further, this explanation of this one, we can see angiotensinogen 2. Angiotensinogen is converted to angiotensin 1 by renin, and this will be converted to angiotensin 2. Now angiotensin 2 has a regular pathway. It will be converted into angiotensin 1 to 7, and this has effect of vasodilatation, anti-apoptotic, anti-fibrotic, anti-proliferative, and this will cause decreased hypertension, decreased cardiac fibrosis, decreased thrombosis, and decreased ARDS. So what happens if SARS-CoV-2 takes over these receptors? So what will happen? Angiotensin 2 will be accumulated, and so it will affect the angiotensin 1 receptors. It can affect angiotensin 2 receptors, but more angiotensin 1 receptors. So these are the receptors. Finally, it will cause vasoconstriction, inflammation, fibrosis, and proliferation, just opposite to these effects. So finally, it will cause hypertension, cardiac fibrosis, increased thrombosis, and ARDS. So this is actually the underlying cause of all these pathologies ongoing in the lungs of the COVID-19 patients affected. So we have the ACE2 receptors in the brain, in the lungs, in the intestines, in the kidneys, and testicles. So all these receptors are affected, and we have the neurotropism effect on the brain, lung effect like pneumonitis, ARDS picture, loose motions, diarrhea, acute kidney injury, but testicular effects have not been documented yet. So course of the disease, we can divide in 3 types of courses the patient can have. Either hyperacute phase, where severe hypoxemia from the beginning, leading to immediate intubation. Second, patient will start moderate or severe hypoxemia, but moderate work of breathing, so it will not be affected a lot. And the third type is biphasic, where the patient will start with the indolent phase and suddenly becomes hyperacute and leading to the intubation, consolidation, collapse, ARDS-like picture. These are the 2 extremes of the COVID-19 presentation. One is the minimal changes, and the other one is the ARDS, bilateral infiltrates, consolidation. You can see in the X-rays also. These are few presentations of COVID-19. As in the first CT, you can see there is consolidation. In the second, we can see ground glass opacity and crazy paving appearance. The third one is mediastinal lymphadenopathy, had been seen also in few cases. Okay, this is the gentleman who actually led to this concept that all this COVID-19 pneumonias are not the pure ARDS, but something else is going on also. So he and his colleagues working in Germany, they write a letter to American Journal of Respiratory and Critical Care Medicine on 30th March, and that we want to present something. And then they wrote the articles also, which is published internationally in multiple you can say journals, plus also the Medscape also took their interview. If you Google the Medscape, if you go to the search of the Medscape, you'll find his name, and all the interviews are there. What he says, this gentleman Gaetano, he says COVID-19 does not lead to a typical acute respiratory distress syndrome. And it is published in American Thoracic Society Journal. Actually, he says that he categorizes the factors into 3 major categories, A, B, and C. The first category is actually the how much severity of the grade of infection. Second, how the affected person responds to the disease. What are the physiological reserves he has, and what are the disease he's already affected, like diabetes, hypertension, and like this. Plus, once the patient is intubated and ventilated, how the body or the lungs respond to the ventilators. And the third, the time of onset between the patient and between the disease and the admission to the hospital. All these factors cause increases the severity of the disease. Okay. When in Massachusetts General Hospital, they have summarized all these factors and which can lead to these overthought about the progression of their disease, that is low risk disease or high risk of disease. They categorize these factors into three. One is the epidemiological factor. The other one is vital signs. The third is the labs. They say and they categorize that one of the epidemiological factor plus one of the vital signs or labs, if are present, then if one epidemiological factor plus one vital signs or one lab factor is present, it leads to the high risk of progression. What are the epidemiological factors? They found the age more than 65 with pre-existing pulmonary disease, uncontrolled diabetes with hemoglobin A1C of 7.6, history of cardiovascular disease, obesity, BMI of more than 30, patient is taking any monoclonal antibodies, or already on immunosuppression, or they're having HIV with CD4 count less than 200. If one of these factors, plus if a patient has a respiratory rate of more than 24, heart rate more than 125, saturation less than 93, and PF ratio less than 300. Or epidemiological factor plus one of the labs, D-dimer more than 1000, CK twice upper limit of normal, LDH more than 245, ferritin more than 500. On admission, the lymphocyte count was less than 0.8 and LDH more than 245. So there are chances that the disease, high risk of progression of this COVID-19. Okay. Now further, we'll zoom down to the three things which will affect the progression of the disease. In the lungs, I will read it and then we'll explain in the next slide. There will be imbalance between VQ, high perfusion, low ventilation, which leads to and high will lead to the work of breathing increased. Moreover, there will be microthrombi, which will cause increased dead space. And finally, there's shunting because of collapse and ARDS. Once, as I told, the ACE2 receptors in the brain and near the midbrain, they will affect the heart also, can cause cardiac arrest and multiple respiratory problems, cognitive issues. Patient can have delirium and have the decreased or absent sense of smell. This ventilators, I think I will discuss later. So let's concentrate on this slide. As I told, there will be imbalance between VQ, high perfusion, low ventilation. So what will happen? It will lead to hypoxemia, will cause increased work of breathing. Of course, the patient will cause increased tidal volume, and the self-increased tidal volume, if patient is not intubated, what will happen? Patient self-induced lung injury. On the other hand, once patient has neurotropism effect, as the ACE2 receptors are in the brain, it will cause increased respiratory drive, increased work of breathing, and same cycle will start. Finally, patient self-induced lung injury. If patient is having sepsis, of course, increased metabolism, increased work of breathing, and enters this cycle. And as such, as we know, the COVID-19 as such can cause acute lung injury. So patient self-induced lung injury plus acute lung injury caused by corona push the patient to the vicious cycle. So these factors which I have mentioned before, their interaction and time-related disease spectrum of, will lead to the two type of phenotypes. One is L, alpha stands for low, and H, high. We'll discuss, I will explain later that what is low and what is high. Just remember the L and H. Okay, this is the further explanation. Once there is hypoxemia, dysregulation of pulmonary effusion. So what will happen? Patient will be either initially will be having low elastance, low VOQ, and low recruitability, and limited PS response, and they labeled it as phenotype L. This is the observation of Gatinino. Then on the other hand, patient like hyperacute phase, like I mentioned before, our patient is having biphasic phase. Initially, he was having this type of like indolent start, and later on enters into this with the collapse ARDS. So what will happen? Patient will be having high elastance, high recruitability, high right to left shunt, high PEEP response, and this will be labeled as phenotype H as per Gatinino. And once this phenotype L, which started with the phase, this patient is having biphasic phase, and he entered first in the L type phase. There is pulmonary microthrombi, and this L type can go into the phenotype H. So this conversion of phenotype L and to phenotype H will change our perspective for the management of the patient. So that's the reason Gatinino is saying every COVID-19 pneumonia is not to be treated as the ARDS, typical ARDS. Okay, once there is lung injury, impaired gas exchange, lung elastance, increased respiratory drive as I explained before, and finally what will happen? Patient self-induced lung injury with the increased esophageal swings, increased tracheal pressure will cause capillary leak, and finally lung edema. So we can say the L type, which was having low recruitability, low elastance, low lung weight, is converted, or dry lung is converted now into the high weight lung and high recruitability lung and high lung with the lung edema or increased weight. So H type, L type is converted now to the H type. So this concept of as patient self-induced lung injury was presented first in 1938 by Barak and Mascheroni in 1988, and they published in different kind of journals at that time also. Now we can see how this transition from L to H type in 7 days in one patient. Okay, this is CT of the patient on admission, and the PF ratio was 95 at that time. And we can say most of the areas of the lungs are aerated, very few areas of collapse and consolidation. And patient was having FiO2 of 80%. Now after 7 days, we can see very less areas aerated. Most of consolidation and collapse of the lung is there. So this is now typical ARDS picture, but surprisingly we have seen the PF ratio not to change much. Before it was 95, now PF ratio 84, but the lung is totally destroyed. So within 7 days, according to Gatinino, L type changed to H type. Okay, this was the concept used by the Gatinino, and this is different from KSMC protocol and like this. He said we will give 15 liters of oxygen, and if saturation more than 95, it will be considered as mild. In the mild cases, we can use CPAP or high frequency laser cannula, and if saturation is not increasing more than 95, go for intubation. This will be considered moderate to severe. And this was his way to estimate this severity. And he used this, he said that we can use either center venous pressure swing, like if swing is in the CVB is 10 centimeter, we can use high frequency laser cannula or CPAP, or if swing is more than 15, means work of breathing is high, so we can go for intubation. Okay, just to refresh you, these are the guidelines Dr. Mahdi and team has prepared in an excellent way with the KMC. So just deviating from the topic and just refreshing you this one, avoiding positive pressure vacillation is recommended. Exceptions, short-term bridge, the ventilator if available. If not available, then we can go for this non-invasive ventilation. Rapidly reversible causes of hypoxemia, for example, the pulmonary edema, there is plugging of mucus or witness small aspiration, or obstructive sleep apnea or tracheomalacia. So these are the exceptions, but try to avoid non-invasive ventilation because of course this spread of infection. If you are using BiPAP, then should be with the HEPA, and dual limb should be there. And other strict airborne precautions, including N95, strict isolation and an active pressure room, ensure mask devices fit well, and there is minimal leak. Now this is the indication for intubation. Is saturation less than 90 or FiO2 more than 0.4 with increased work of breathing, or rapid progression of COVID-19 disease in terms of the high FiO2 requirement or worsening of the radiology sets like X-ray and CTs, or evolving hypercapnia with pH of 7.3 or less with PCO2 more than 50, then or hemodynamic instability, multi-organ failure, and also of course the clinical judgment of the patient. The doctor. Now come back to the phenotype screening, like Gatinino strain, Gatinino article, and he said the strains, we have two types of strains. So what he did, intubated and ventilated the patient, and upon mechanical ventilation, we put volume control ventilation and started with tidal volume of 8 ml per kg body weight. given the PEEP of 8 and respiratory rate initially with the end-tidal CO2 was being kept around 35. What were the targets on carrying ventilation? Saturation target was more than 90, and PO2 more than 60, PCO2 45, or pH more than 7.3, plateau pressure less than 28. So this was our target. And by setting the 8 ml per kg of tidal volume on the initial phase, and they wanted to keep the driving pressure less than 15. If they were able to keep the driving pressure less than 15, they continued with the 8 ml per kg, which is relatively high as per the ARDS protocol. Okay, so if they could not keep the driving pressure less than 15, they reduced the tidal volume to less than 6 ml per kg body weight as per the typical ARDS protocol. Now, the next thing they followed this, they wanted the saturation should be more than 90, and with the FiO2 should be less than 0.7. If they could not reach this target and saturation less than 90, in spite of FiO2 reaching the 70, added neuromuscular blockade and gradual increment in the PEEP reaching up to 15 centimeter of water. And again, the targets were saturation 90, PO2 more than 60, PCO2 less than 45, blood pressure to be kept less than 30, and driving pressure should be less than 15. If these targets not achieved, even when reaching the PEEP of 15, and patient was having saturation of 90 with FiO2 more than 70, and they checked the compliance. If the compliance was more than 40, it means it was compliant lung, and the labor is at phenotype L. It means low elastance, low recruitability, and keep the tidal volume 8 ml per kg and PEEP of 8 to 10. If compliant is not more than 40 or it's considered non-compliant lung, then the patient has typically ARDS picture, and it should be treated as ARDS, like high recruitability, prone responsive, PEEP responsive, APRV, and patients having high elastance. So this is the way he labeled this lung disease in COVID-19, that every typical heavy pneumonia is not typical ARDS. We should consider that it can be L type and can be H type, and the management will be different, because in L type, we can give the a relatively high tidal volume of 8 ml per kg, but PEEP not to be increased like ARDS protocol. Too high, we should reach up till 10 of PEEP of 10 only. And the other way, if like I showed before, this CT, this one, there we can apply the typical ARDS, but here we cannot go like typical ARDS treatment. So this way he classified the pneumonia and COVID-19, L type and H type. So further, if hypoxemia refractory to prone positioning or a PRV for 6 hours and not improving, then we should consider ECMO, and we should contact the ECMO center, or if ECMO is available, like in King Saud Medical City, we should contact ECMO consultant, and they can tell us patient is a candidate for ECMO. If patient is a candidate for ECMO, it's okay, we will go for VV ECMO. If not going for ECMO, of course, we have to decide that what should be the code status of the patient, and we should review our targets, strategy, discuss with the family, and if the code status can be declared, we can declare the code status. So in summary, early recognition of hyperacute disease, need for immediate intubation and high risk of cardiovascular events, short and judicious use CPAP, non-invasive ventilation for hemodynamically stable patient with moderate hypoxemia, low respiratory drive, and low inflammatory phenotypes. Be aware of biphasic course once the indolent phase changes to the hyperacute phase. Early differentiation of L phenotype with the preserved compliance, dysregulated pulmonary perfusion. Do not use high PEEP, and this is not ARDS. So this was the summary of getting article. I hope you will understand, and always remember, it might be stormy now, but rain doesn't last forever, and sun will shine, inshallah. Thank you.
Thank you, Dr. so much, actually. Do you have any questions for the pathophysiology? Thank you so much. Actually, inshallah, tomorrow in details, Dr. we have the pathophysiology of the management of such case, not pathophysiology, the management of the such case. So about the pathophysiology pathophysiology, I think it's clear for all of us, and we don't have any question. Thank you, Dr. Waqas.
Thank you, Dr. Madhi. Thank you very much.
Thank you so much. Now we can move to Dr. Bassem. Dr. Bassem, are you available here? Dr. Bassem, wait.
There is someone raising the hand, Dr. Pablo.
Raise hand. Yes, Dr. Pablo. Dr. Pablo, you can talk. Your mic is unmuted. Dr. Pablo. You can unmute him, Ahmed, please.
He can unmute himself now. Dr. Pablo, you can unmute him from your side. I think there is a problem from his side, Doctor.
Yes. I think we received question now. We start to have question now. Dr. Waqas, you're still there?
Yes, yes. Assalamu alaikum.
There is question now in the chat room until Bassem will
Yes,
join
yes.
and Dr. Pablo will fix his audio. Is there any more data about this phenotyping beside Gatanoni?
Actually, no. But this is the most popular talk nowadays in the media since 30th March. So if you Google it, this is the very hot topic, and I think it appeals if you think logically. Because once the patient X-ray and CT is not destroyed too much, and I don't think so. You will get any benefit for increasing continuously beyond the limit and increasing the PEEP to too much extent where patient is not the X-ray is not destroyed or it is not showing the collapse airways or something like this. I don't think so. Dr. Madhi, you can elaborate further. I think you are best in anesthesia.
Actually, the one who started to have this is Gatanoni, actually, and most of the studies later on, or even worldwide, they are relying on the Gatanoni notice about the phenotyping, about the compliance. But actually, it is reasonable. If you have the COVID patients, you can find it. Actually, it is reasonable to implement in most of the COVID patients. Usually, they are in the early stage. They still have the normal lung functioning or elastance. Later on, they start to have the typical ARDS. So most of the literature or most of the concepts coming specifically from Gatanoni and his colleagues, Mirani and those people actually from the USA and Germany. But even though still some figures with ARDS, which is not following this the pathophysiological process in the line of management. We have another school for the management, which is almost relying on the recruitability of the lung. I will not go in details, but there is, but the commonly they are following Gatanoni. Last question about what are the comment about proning tomorrow will be discussed in details. What are the complications seen if we apply time-tested ARDS protocol in both phenotypes? This also will be commenting tomorrow about ARDS. We have a lecture about ARDS in details. We can just, Dr.
There's one question about ACE inhibitors.
Yes, ACE inhibitors.
Yes. Okay, this is a good question. And ACE inhibitors, if you are already on ACE inhibitors and angiotensin II receptor blockers, or your patient is taking, continue that. It doesn't increase the worsening of pneumonia, but actually the further studies, it shows decreases inflammation in pneumonia. So don't stop any ACE inhibitors or ARBs if the patient is already on or you yourself are taking.
Yes. There is some Dr. Abdelhakim answer some question in the chat room.
I think he has a question.
How to decide when the L is it changed to H only by compliance or any other data?
If the patient is intubated and ventilated, and you are your targets are not achieved, like I mentioned before, there are targets like PO2 60, PCO2 45, pH more than 7.3, your targets are not achieving, and you are increasing the PEEP and reaching the level of 15 centimeter, and still FiO2, PO2 is not improving. On the other hand, you have already paralyzed the patient, FiO2 is reaching the 70, then I think check the compliance, and it will tell you about the compliant or non-compliant lung. In non-compliant lung, of course, you will go for this ARDS protocol. In compliant lung, still I think you have time to continue with this high tidal volume and the PEEP reaching up till 10. And X-ray and CTs, of course, they will tell you.
Yes, I can add actually for the L type and H type, there is some, we don't have it. What we have actually in our center is the compliance, which is easy to be done bedside, but still you can have some like transesophageal probe, you can use it actually to define, or they are relying sometimes on swinging of the central CVP. Some studies said like that, in the swinging CVP you can rely on. Another said you can rely on recruitability assessment bedside, but the practical point, what we have is compliance. Thank you, Dr. Waqqas. I think we can move. Dr. Basim is available now.
Thank you very much. Thank you, Dr. Nadia. Thank you, everybody.
Welcome, Dr. Basim. I think now you are muted. Work up in COVID. So it will take, I think, 6 minutes from your lectures.
No problem. I have a really short lecture. Can you hear me and see my presentation now?
Yes, it's clear.
Thanks a lot, Dr. Ahmed, Dr. Waqqas, and speakers, and all the committee. Thanks, attendees, for taking from your time. I will not take much from your valuable time, inshallah. And my short talk is about the workup of COVID-19. Obviously, the workup starts with confirming the diagnosis of COVID, and this is currently the gold standard is by PCR, reverse transcriptase PCR. This is the current gold standard, and it relies on identifying the viral antigen in respiratory secretions of the patient. Unfortunately, the sensitivity is not very consistent. It is affected by the sampling technique and by the viral shedding of the patient. So sensitivity can be as low as 70%. And also it is advocated that lower respiratory tract samples are superior to nasopharyngeal swabs. So what we take from this is if a patient is clinically suspected and he tests negative initially, it doesn't necessarily mean that he is truly negative. The test can be repeated another time or even 3 times until you are confident the patient is negative. On the other hand, there's a lot of talk nowadays about the so-called rapid diagnostic tests. These are, there are like over 100 commercially available kits, not yet available in the kingdom, I think, but they will arrive soon. So these are divided into 2 main categories. There are the tests designed to identify the viral antigen through ELISA, and the tests that identify the host's immune response in the form of immunoglobulin M and G. The immunoassays to detect the viral antigen can be ready within 30 minutes. This is compared to 4 hours for the PCR. By the way, it doesn't really take, it takes 2 to 3 days in our hospitals for logistic reasons. PCR takes in the lab 4 hours. As compared to 30 minutes for the rapid diagnostic tests. But the problem is the sensitivity is really low, and roughly you can say 50% of patients will test negative with these tests as of now. We are waiting for improvement, of course, but this is the current status. The other category are the rapid diagnostic tests that are designed to detect the host antibodies. And the main drawback of this is that it will not turn positive until after several days of the infection to allow time for the body to form the immunoglobulins. So you cannot rely early on it in diagnosis. It also have a high rate of false negatives and false positives. False negatives because it depends on the host immune response, which is in turn affected by the age, nutritional status, things like HIV. So in these conditions and some others, the patient can test negative while he is actually having COVID. On the other hand, there are reported cross reactions between COVID-19 and other pathogens, especially of the coronavirus family. So patients can test positive while there are actually negative, which affects the specificity of the test. Now, having secured the diagnosis, obviously, if we imagine a patient coming into the ER with the clinical context, he will have the swabs and he will also have the basic investigations that are done for everyone who gets into the ER. Many of these carry that have been postulated early on during the pandemic from the Wuhan community. Some tests have been shown to correlate well with the patient's outcome, whether developing ARDS, getting into ICU, dying. There are many reports that have linked many labs to the outcome of the patient. These labs can help in risk stratification of the patient, because we know some patients look well, relatively fairly well initially, and then they rapidly deteriorate. So these tests may help identify those patients and hence maybe stratify them to being admitted to ICU while the clinical data are not that bad. So some of these, there are many reports, but the most solid are the ones I postulated here. These include lymphopenia, neutrophilia, high total leukocytic count, increased neutrophil to lymphocyte count, also increased enzymes, CK, LDH, troponin, and increased D-dimer. These all carry a higher risk for the patient developing severe disease. Inflammatory mediators, CRP, ferritin, procalcitonin, labs that denote complications like DIC, high liver enzymes, acute kidney injury. These all have been associated with worse outcomes and can help early triage within the ER. And they also can be used to follow up the patients inside the ICU for to get an idea whether the patient is improving or actually deteriorating. General labs should always be done, like in all ICU patients, to monitor for complications, but they also carry valuable information as for COVID itself, like in CBC with differential. And it is important to make it with differential every day, because the lymphocytic count, we said, and the neutrophil to lymphocyte count does carry prognostic value. So it is important to daily do a differential. Obviously, chemistry, liver function tests, ABG, VBG, ECGs, cardiac enzymes, all are a part of the workup of a patient, initial workup and continuous monitoring of COVID suspected or COVID positive patients in ER than in ICU. Radiological studies have this is a typical look of a chest X-ray of a COVID patient, COVID pneumonia, obviously. You can notice the more peripherally distributed pulmonary infiltrates than central. Also, this is a typical CT. It again carries a ground glass appearance, more peripherally distributed than central. Although there are striking features of the radiological picture of COVID, it should not, contrary to what was postulated early on during the pandemic, these should not be used merely to diagnose COVID, because there is a high risk of exposure. So PCR is the way we diagnose. Obviously, you will need initially a chest X-ray, but repeating the X-ray daily on routine basis or doing a CT just to confirm the X-ray findings is the risk-benefit, although it is beneficial, but the risk-benefit ratio for this is not really towards. It's better to follow your patients with point-of-care ultrasound if possible. It should always be prioritized over X-rays and CTs to minimize exposures, and in good hands, they are non-inferior to these radiological studies. CTs, of course, still have room in workup of the patient, but this should be restricted only to look for alternate diagnosis or a coexistent diagnosis, like if you suspect on the X-ray that the patient is having a cavity, or clinically or sonographically you suspect PE, then this is an indication. But as we said, doing a high resolution CT chest for every patient with COVID just to see the extent of involvement should not be our routine. There are also many complications that are linked to COVID and to critical illness, generally speaking. So acute kidney injury, you will need urea, creatinine, VBGs to follow these up. Liver injury can be either due to the pathogen itself or due to the medications that we are using. DIC is a poor prognostic sign, and so if you have signs or suspicion of DIC, you need workup for this: fibrinogen level, D-dimer. Secondary infection are an important contributing to worse outcomes to the patients. These can be followed by procalcitonin, but also obviously you need to send cultures from different samples to if you suspect that the patient may have developed a secondary bacterial infection. Thromboembolism is reported as higher than expected in COVID patients. So we should practice high vigilance in our patients and heavily investigate them with lower limb Dopplers, spiral CTs, CT brains, angiographies for arterial infarcts. So obviously these all are indications for further workup to search for complications. Finally, as we said, point-of-care ultrasound has been gaining ground in ICU for the past over a decade, but right now in the middle of this pandemic, it has even gained more ground because the main concern is minimizing exposure and making less contacts of the healthcare workers with the patients. So this is the reporting form of our cluster in point-of-care ultrasound. You can notice that it involves scanning of the lung, heart, and lower limbs, and there are detailed reporting spaces for everything. B lines, pleural lines, consolidations, and the cardiac function, LV size function, LV RV, and the volume status of the patient, and obviously compression of the lower limb veins to look for DVT. As we said, in good hands, it is non-inferior to classic studies. But always remember that it is operator dependent and it heavily relies on the experience of the person. So COVID may be a good opportunity for all of us to learn from the experts, but please do not over-rely on your scan and make it as good. To make it short, yani ultrasound is good is as good as the operator is. Remember that, and do not make serious decisions based on a non-expert opinion of ultrasound. So this concludes my very short talk, and thank you. If you have any questions, please.
It's really short. Thank you, Bess. But good to have time. We actually have some questions for previous speakers. Until now, we don't have questions for your side from your side, or we have earliest test to diagnose COVID.
Earliest
test to diagnose COVID.
Well, as we said, the point of care or rapid diagnostic test will let you know in 30 minutes, but the problem is the high false positives and false negatives. To start with, these are not yet available, but when they are available, if a test comes positive and the patient is highly likely to be positive, this probably concludes a diagnosis. But the problem is when it tests positive, when the patient is not really having the full clinical picture, or if it tests negative. So to diagnose, confirm a diagnosis of COVID, it is the PCR. And as you know, it takes a few days. So this is why we treat suspected patients the same as positive patients. It has been suggested that CT tests, as we said, can confirm a diagnosis with high level of accuracy early on, even before the PCR. But as we just said, the risk-benefit ratio is not towards doing CTs for every suspected patient. This is why we still will rely on PCR.
Thank you, Dr. Bassem. I think if we have previous speakers, I have some questions from the YouTube, actually from YouTube. So there is one question for Dr. Waqqas and another few questions for Dr. Tasmia. Muhammad Abazim asking Bassem before we go to the previous speakers.
Thank you, Muhammad Abazim.
Yes. Are we have focus team?
Yes, we do. It is headed by Dr. Salman and Dr. Demetrius, and they have their own team. They are working, I understand they are working on training now, and we have a protocol, and I just showed you the reporting form. So I hope we will be able to consult them soon to assess our patients initially and regularly thereafter.
Another question from Dr. Shakir Ahmed.
Yes,
you can read it. At what COVID score do we go for testing in KSMC?
I really don't know. Maybe this should be answered by Dr. Tasmia. I don't really know the answer to this.
Increased incidence of coagulation. So anything to monitor about that, like platelets, INR, BT?
This is a really good question, and thank you for that. As we said, D-dimer is high in most cases, and if it is above 1,500, it carries a risk for progression to worse prognosis. But knowing this, it is important not to jump into conclusions that to go for a spiral CT, for example, if D-dimer is high. It is a part of the disease itself, and I think it has been explained by Dr. Waqqas shortly. So screening patients for thromboembolism should follow the same as any critically ill patient. When clinically suspected, like the radiological findings do not explain the high oxygen demand of of the patient, then you start thinking of a PE, for example, if the patient develops sudden deterioration. On the other hand, arterial thromboembolism have been reported also. So if a patient is on light sedation and not waking up, then this is the time you should start thinking that he might have developed a cerebral infarction, and so on. But lab-wise, high D-dimer per se is not an indication to go for radiological scanning. You're muted, Dr. Mod.
Can you read it?
We missed the first part.
Yes. I'm asking about the continuation of the previous question about the coagulation profile or assessment of coagulopathy. D-dimer is the result of thrombolysis. D-dimer is the result of the maybe micro and macro thrombi, actually.
Exactly.
But before that, anyhow, it is a must to scan all the staff who treated COVID patients, even if they are asymptomatic, and how frequent they will be scanned, especially if they are assigned to treat COVID patients. I think this question for Dr. Shahzad, and he answered in details. And just yesterday, he highlighted on the healthcare worker assessment for who's dealing with the COVID patient. We will post in the group this safety guidelines by the Ministry of Health, just released yesterday. It have everything about the healthcare dealing with the COVID patient. I have question from the queue for Dr. Waqqas. Dr. Waqqas, are you with us, Dr. Waqqas?
Yes, Dr. Mati. Assalamu alaikum.
Dr. Altaf asking, during this L to H type lung injury, conversion was any cardiac factor contributory factors to, or it is isolated lung injury?
Actually, as I mentioned, they have studied the interaction of all the factors in the slide where I mentioned the Massachusetts Hospital, General Hospital slide. I told that epidemiological factor plus one of the other factors like Dr. Masim also mentioned, this high LDH, high procalcitonin, and all these factors. These are actually cumulative effect of these factors were included in this observations also. So we cannot say simply that this was only the sole effect of this COVID-19 that has caused the damage of the lung. So this was the contributory factors as well. We cannot rule out these.
Thank you, Dr. Waqqas. We have many questions regarding the remdesivir and the anticoagulations. It will be touched in details by Dr. Bashir in the upcoming lecture. Most of our staff in the WhatsApp, in the YouTube, they have many questions for Dr. Tasmiyah about the scene like ER settings, which we don't have area for donning and doffing, and how we protect ourselves. I think it's very difficult questions. Any specific precautions in open areas like ER for donning and doffing? So Muhammad Saeed, I think these questions refer to Dr. Tasmiyah, and I think they have their now negative pressure room specific for COVID, or we can consult the infection control to reply you specifically on this question, because most of you are really are the ER all the time. Thank you so much. I think now we have no more questions. So it is 12. We can proceed. Thank you, Dr. Bassem. Thank you, Dr. Waqqas. Thank you so much. Our next guest speaker. Oh my God, he always he posted his drugs already. Dr. Bashir, welcome, Dr. Bashir Abdurrahman, clinical pharmacist working with our ICU. He will talk about the pharmacotherapy. Feel free to ask anything about the medications. He's trapped in the north area. He's so free. He can answer you until 1 a.m. Bashir, you are online.
Yes. Assalamu alaikum.
Alaikum assalam wa rahmatullahi.
Thank you, Dr. Ahmed, and for everyone. Thank you for having me today or tonight. So I will quickly start my presentation, and I will try to make it simple as Dr. Bassem presentation, inshallah. The main goal of this presentation to aware you about the pharmacotherapy part of COVID-19 in cluster 1 protocol. So it's a little bit confusing because although we don't have definite management of COVID-19 till now, many drugs have been used in vitro, but unfortunately till now we don't have a definite management. We have some medications we are using as supportive medication, and others we are using as unapproved indication or as investigational drugs. So we will touch those drugs now. Okay, so as a quick introduction regarding COVID-19 virus, it's attaching to the receptor binding gene region that the same region that SARS coronavirus and the virus has been shown to use the same receptor, which is angiotensin converting enzyme 2, as mentioned by Dr. Waqas. And by the way, regarding to the question, it's not increasing the probability of affecting or being affected by COVID-19, but of course, you know that if someone will use S inhibitors or ARBs, this may enhance the expression of more S2 receptors. So if they withdraw or discontinue the medication, we suspect they may have severe and more severe effect of COVID-19. So as mentioned by Dr. Waqas, it's of course, please, it's recommended to continue with S inhibitors or ARBs for those patients. And the closest RNA sequence similarity is to the bat coronavirus. So they think it's most likely bats the primary source. Unfortunately, this is positive sense RNA virus, so enveloped virus. So its entrance to the cells is very easy, and attachment also easy attachment. So as a result, the replication will be very fast and high, but it's not easy to treat. So we have many advantages in the virus side. When it affects someone, it's not exclusively dangerous for advanced age. Also, some severe cases we saw with young people, but of course, predominant severe cases with advanced age people and with those with comorbidities. By the way, these comorbidities may make us suffer in another way, that we may not be able to give many medications because of renal impairment, liver impairment, or septic shock. Some disease will prohibit us to give some supportive drugs or some drugs. So comorbidities will affect this part also. Okay. I think many will ask why we do not make a drug or find a treatment that within this time. In general, drugs development is a longer process, and it may take up to 12 years till final approval. So if the FDA may take, the company will take 12 years till get the FDA approval. But in such situation, we have something called fast track approval, allowing doctors and patients to have access to unapproved uses, like what we are doing with hydroxychloroquine. We are using this drug with unapproved indication for this situation and for this disease. Now, regarding to the management, we have two parts: home care for those asymptomatic patients or mild symptoms. The main issue, we should focus on prevention of transmission to others and monitoring the clinical deterioration. Then maybe the patient need hospitalization. For outpatients management, mainly good hydration and antibiotics if needed, and analgesics. But for hospital care, we have glucocorticoids, nebulized medication, NSAIDs, antimalarial, antiviral, interleukin-6, pathway inhibitor, convalescent plasma, vitamin C, zinc. All of those we will discuss briefly. I will start with glucocorticoids. We have one good and two bad previous experiences with the glucocorticoids. With SARS, we used to use this glucocorticoids because acute respiratory distress syndrome patients. But with influenza, we can see increase in mortality with corticosteroids. And for MERS-CoV, we have delay viral clearance with this. So overall recommendation by WHO and CDC that glucocorticoids should not be used for those patients with COVID-19 unless there is other indication. Other indications like COPD exacerbation, or regarding to ICU, sometimes we have ARDS patients with COVID-19. For those patients, we may use corticosteroids. Usually, early presentation, we are not using any corticosteroids, but a few days later, maybe the patient will be in shock. So we may use hydrocortisone 50 milligram Q6 hourly for septic shock issues. And late with those patients with ARDS, we may use methylprednisolone and the suggested dose 100 milligram Q6. So usually we are not using corticosteroids for all patients, only for special indications. We are using corticosteroids, not for COVID-19 purpose. For nebulized medications, of course, those medications may be a result generating a procedure, so we need to avoid. So if we need bronchodilators, it's preferred to be given by meter dose inhalers if we can. And for any other nebulizers we are using as adjunctive therapy, like some antibiotics, you should stop and you should not continue with nebulized medication, of course, to protect the healthcare workers. For NSAIDs, we had this let's say the warning from WHO on 18 March, and they mentioned that we should not use ibuprofen specifically or NSAIDs generally as anti-inflammatory drugs with those patients with COVID-19. This came from some observation from French clinicians. They suggest that those patients, even young patients, they use NSAID, they have negative impact on disease outcome. And few young patients who received NSAID in early course experience severe disease. But later on, we have more data, and the EMA, WHO, and other agency, they mentioned that there is no contraindication to use NSAIDs, and do not recommend that NSAID should be avoided. But we will keep it the last choice as antibiotic. We will start with acetaminophen or paracetamol as the first choice as antibiotic, and we can use NSAIDs later if not controlled, but with lowest effective dose. We will start not full dose, we will start with the gradual dose or lowest effective dose. This is for COVID-19. What about those patients already on NSAID? They can continue their medication. And for those patients chronically using this medication, they can continue unless there is, let's say, side effect like acute kidney injury from NSAIDs. This is something else. You can stop the drug for that. So NSAIDs can be used, but we, as antibiotics, it's the last agent to be used with lowest effective dose for those patients. Chronically use those medications, they can continue. For chloroquines, hydroxychloroquine, they well-known antimalarial drug. We are using those to minimize symptoms of inflammatory immune disease such as lupus and rheumatoid arthritis. In vitro, they showed very good effect that they can prevent the SARS-CoV-1 and 2 viruses from attaching and entering the cell. But in vivo with the humans, there's some argue regarding the efficacy with hydroxychloroquine and chloroquine. But by the way, we are still using, and they are the first line management with the patient unless there is contraindications. We know there is many side effects and drug-drug interaction with hydroxychloroquine and chloroquine. The most important QT. So we are trying to specify with our protocol, our guideline in the cluster one. We will see later, but this is a brief that if the patient under 40, but they are at very high risk of QT prolongation without respiratory symptoms or mild respiratory symptoms, you should not start hydroxychloroquine for those patients. But with severe patient, advanced age, immunocompromised patient, you have to start even with prolonged QT. But if there is a prolongation of QT, you have to consult cardiologist. If there is no prolongation, you can start and monitor QT. So it's weighing this the benefit against risk for those agents. Between both of them, hydroxychloroquine looks to be better and more efficient. In the States, the FDA issue an emergency use authorization to allow the use of these agents in adults hospitalized for COVID-19, as we mentioned. This is a fast track. Optimal dosing till now not uncertain. There is some good results with 200 milligram Q 8 hours, but our protocol 800 milligram first Q12 hour for the first day, then 400 milligram daily for 4 to 7 days. If not available, you can use chloroquine, and please take care if we have the chloroquine sulfate or chloroquine base. If chloroquine sulfate, you will give 1 gram, then 500 daily. And if the base, you will give 600 milligram, then 300 milligram. This is the study, but till now, there is no, it's not officially published yet and not peer reviewed by a good journal. The result of this randomized study, they claim that hydroxychloroquine will have a faster improvement in fever, cough, and chest imaging, and it's better than the chloroquine. Regarding side effects, you know, the majority of patients, up to 90 patients, will not suffer from any side effects, especially QT. So we have the green light to go. But for those patients with high risk for QT prolongation, or we have another drugs that may cause QT prolongations, we have to weigh the risk to benefit depends on whether hydroxychloroquine and azithromycin or azithromycin is necessarily necessary for this patient or not. As I mentioned, if we don't have respiratory symptoms and young patient, we can wait and we will not start hydroxychloroquine. But for those immunocompromised patients, I think with the benefit weigh the risk, so we can start. Even if we will start, we have to monitor drug toxicity, of course, for cardiomyopathy, retinal toxicity, and we have to monitor drug-drug interaction with those two drugs. And we have to monitor and report any adverse drug reaction we are facing. Regarding the QT, we have this graph. We can check the QRS pairs. If it's not prolonged, you can go with hydroxychloroquine immediately if the QT less than 470. If between 470 to 500, you can start with caution. You can check if there's any drug-drug interaction. You can reduce other medications or discontinue other medications if they can cause a QT prolongation. For QT more than 500, do not start until you have cardiologist clearance. But if QRS more than 120, already prolonged, if the QT less than 520, you can start immediately. Between 520 to 500, you need to start with caution and to discontinue any other drugs if you can that may cause QT prolongation. But if more than 550, you need to consult cardiologist before you will start. Anyway, if you will start the hydroxychloroquine or chloroquine, you have to monitor daily QT. And if there is an increase by more than 50 millisecond anytime, you have to stop the medication and to consult the cardiologist. For this one, I only want to mention that you should correct electrolytes before you will start monitoring ECG and QT. Please make sure that you have optimal magnesium and potassium and you can replace. And we mentioned this by the protocol or the guideline. Last thing regarding chloroquines, that you should monitor those side effects: ophthalmic, hematologic, oncologic, like hemolysis, especially for those patients with G6PD, leukopenia, thrombocytopenia, endocrine, severe hypoglycemia, especially for those patients with insulin dependent. Usually we are reducing the insulin by 25%, 20 to 25% if we will start one of those agents. And for cardiovascular, of course, a prolonged QT interval, respiratory bronchospasm, hepatic, we will have abnormal hepatic function test. By the way, usually we are not stopping the hydroxychloroquine unless the hepatic enzymes more than 5-fold the normal. Regarding remdesivir, this is a new drug for Gilead company. This one IV novel nucleotide analog that activity against SARS-CoV-2 in vitro, and it's considered as a broad spectrum antiviral. It was used before for MERS-CoV, SARS, and Ebola, tested for them, but unfortunately the result was not that good. For COVID-19, we are using 200 milligram loading dose, then 100 milligram once daily, up to 10 days. Okay, but side effects, it's not that dangerous, only GI side effect. We have some issues regarding remdesivir. That's why I mentioned it's not an ICU drug, because there's many exclusion criteria and we cannot use this patient if we have any of those, like patient on inotrope, or patient with severe renal impairment, patient on dialysis or hemofiltration, patient with severe liver injury, patient with other antiviral. All of those, we should exclude the use of remdesivir if we have any. For ICU patients, I think it's very difficult to find a patient without inotropes, without renal impairment, without dialysis for any reason, without liver injury, with COVID-19 and admitted to the ICU. So this is one thing. Another thing, for cyclodextrin, the vehicle used with remdesivir, it's very toxic if accumulated in the body. So with those patients with renal impairment, severe renal impairment, we cannot use this drug for sure. This is first thing. But regarding the new study published a few days ago, remdesivir likely has some clinical benefits. Why it's likely to have some? Because there is no difference in mortality, unfortunately, but there is some difference as in the result, that faster time to recovery. The difference between them, they measure the median 11 versus 15 days. This trial, a huge randomized or big enough randomized trial, more than 1,000 patients, and they found there's trend toward lower mortality. It's only trend, it's not statistical significant. Even with this large number of patients, it was 8 versus 11.6. But in contrast, we have another study from China that it's also randomized, almost a quarter of those of the previous study, 237 patients. Remdesivir and the placebo had similar times to clinical improvement, median 21 versus 23, and mortality rate almost the same, 14 versus 13. So it's very conflicting results. Till now, we will tell that remdesivir likely has to some clinical benefits, and the only benefits in fasting the time till recovery. Like for those lopinavir and ritonavir, those combined protease inhibitor we are using for HIV patients. In vitro, there was some effect, but unfortunately with the trials appears to have little or no role in the treatment of COVID-19. Regarding to this study, over 200 or 199 patients, there was no difference in time to clinical improvement and mortality 28 days. And after those studies, the ISCM and the Society of Critical Care of Medicine Surviving Sepsis campaign recommendations suggest against the routine use of lopinavir and ritonavir for critically ill patients. So we mentioned clearly in our protocol that any patient will start with lopinavir, ritonavir should be according to ID approval or advice. It's not a regular therapy for COVID-19. Most of the results shows there is no benefit of this one. Favipiravir, also a hopeful drug, promising drug, RNA polymerase inhibitor. It's only available in Japan and Asian countries. Till now, we don't have it here in Saudi Arabia. The only problem with the results of this medication, those patients were not non-severe patients with oxygen saturation more than 93%, but the result was excellent, faster rates of viral clearance 4 versus 11, and more frequent radiographic improvement 91 versus 62%. We are waiting for the next study. There's some limitation for this one, as I mentioned, that the improvement come with administration of all other drugs. It's not it was not controlled and not randomized study. Another thing, it's contraindicated in pregnancy. Even male must avoid intercourse for 4 weeks if they use favipiravir. Regarding convalescent plasma, it's the administration of plasma from donor who had completely recovered from COVID-19. We have few studies, one of them on 5 patients only, but the result was good because those were very critical patients, on intubated patients, and they became better. But we have some logistics issue, logistic challenges because finding appropriate donors and establish testing to confirm neutralization activity of a plasma, it's very difficult. We are doing a protocol right now for this convalescent plasma. We are trying to collect the information regarding patients recovered from COVID-19, but the collection of a plasma and to match with donors and recipient is a little bit difficult and need a lot of logistical issues. Regarding interleukin-6 pathway inhibitors, tocilizumab, those drugs are used, this drug specifically, we are using for cytokine release syndrome. It's not for the COVID-19 or the viral infection. It's for the complication of the viral infection. For some patients, they are not, they cannot handle the cytokine syndrome. So if we are giving those medication, we will have milder symptoms and milder severity of the disease. We can give up to 3 doses of this one per a day. And usually we are giving 4 to 8 milligram per kg. There are there is other medications, but still under investigation. Tocilizumab is the only one till now used. By the way, there was no published clinical data except only one small retrospective study with COVID-19 patients. Regarding supportive therapy like vitamin C and zinc, We have here vitamin C. We have very good relation between vitamin C and ventilated patients, but we don't have any data regarding vitamin C with COVID-19 patients. But we can extrapolate that some patients may get benefits, especially ventilated patients. Usually, our need is 0.1 gram per day. For those ICU patients, we need much higher doses. We are reaching grams. Almost we are giving 1 to 6 grams per day. Usually we are giving 4 grams per day. And it may reduce length of stay by 7.8% in the ICU, and it may reduce or shorten the duration of mechanical ventilation by 18%, which is very good. But regarding COVID-19, we don't have any evidence. So there is no harm of using vitamin C, and it's there in our protocol that you can use for ICU patients. Now I will talk about the COVID-19 protocol, about the pharmacological part. Okay. For those patients, we have suspected and confirmed cases. For suspected patients, we will do as we are doing with any other ICU patients. We will give DVT prophylaxis, normal dose, 40 milligram OD, omeprazole, 20 to 40 milligram OD, antibiotics if needed, and medical management as usual. If confirmed the case, if the patient need convalescent plasma, as I mentioned, we have special protocol and guideline. We will go to this one. If not, we will start DVT prophylaxis according to the D-dimer if we have it, and according to the weight of the patient. We will not use the regular dose. I will explain in details the anticoagulation management and the prophylaxis for those patients. For those patients, if you will start any antiviral except oseltamivir, you need ID approval. If you will start lopinavir, ritonavir, you need ID approval, remdesivir ID approval, and any antiviral, you need ID approval. There is many contraindications, many drug-drug interactions. Some, as I mentioned, they have no role in COVID-19 also. So the use of those medications, especially some of them we are using as anti-HIV, and we do not want to cause resistance for those medications. So we should be very careful with those medications. Now, regarding those confirmed cases, routine use of corticosteroids, as I mentioned, not indicated. Empirical influenza treatment can be done with oseltamivir, and if you will use hydroxychloroquine or chloroquine, you need to send G6PD screening immediately, and you can use vitamin C, vitamin D, thiamine, and to correct the magnesium and potassium if there is any disturbance, and to make them to make it as optimal in the optimal range if you will start any drug that may cause QT prolongation. Regarding in details, if you have mild to moderate patient, if asymptomatic and there is risk for QT prolongation, don't use hydroxychloroquine. Monitor the patient and give supportive therapy and symptoms relief medications. But if any age and the QT is low, you can start for the patient hydroxychloroquine, especially if those patients with comorbidities, if those patients immunocompromised or advanced stage. But if we have a QT prolongation with those patients with a QT prolongation and immunocompromised or comorbidities, you can start hydroxychloroquine, and you need to consult cardiologist and clinical pharmacist. The clinical pharmacist will try to reduce other medication or discontinue other medication that can cause QT prolongation. And for bacterial infection and influenza management, you will start treatment with ceftriaxone, azithromycin, oseltamivir. If hydroxychloroquine is not available, you can start with chloroquine. Okay, next level. If not mild to moderate, it's now severe case. You have to start hydroxychloroquine, and you can start lopinavir, ritonavir, of course, after ID approval. and you will upgrade the management of bacterial infection to tazocin plus azithromycin and vancomycin if there is any risk of MRSA. And according to ICU consultant, if there is any risk for fungal infection, if the patient in septic shock, you can start echinocandins or antifungal. This will be done by treating consultant, which is ICU consultant. And also if hydroxychloroquine not available, you can start chloroquine. The third level, if the patient is a critical case, now you will start hydroxychloroquine. It's preferred to start remdesivir, favipiravir if available, once available. If not, you can start lopinavir, ritonavir, all of those antiviral after ID consultation. And you can start piperacillin, tazobactam, which is tazocine, azithromycin, vancomycin. But antifungal here we will start to think about aspergillosis, and the choice is voriconazole or amphotericin B liposomal. It will be decided by ID consultant. For interleukin 6 inhibitors, tocilizumab can be started by the ICU and ID consultant also. And regarding to the dosing, also we offer, this is a summary for all medication and all dosing and duration of the medication. Hydroxychloroquine, 400 milligram Q12 hours for day 1, then 200 milligram Q12 hours for 5 to 7 days or 4 to 7 days. So you have here as a reference all the medication. Now I will go to the anticoagulation. This is the last slide of my presentation. Anticoagulation pathway for suspected and confirmed case. I will, yes, it's here. 1 minute, yes. Okay.
We're on time, Dr. Bashir.
Yes, 1 minute only. Now we have suspected cases. Okay, suspected cases, if we have normal kidney function or creatinine clearance more than 30, you will go with enoxaparin 40 milligram. And if there is renal impairment, you will give adjusted dose of enoxaparin or you will go with heparin. This is in the suspected cases. If there is confirmed case, we will send for D-dimer. But first, if there is no contraindication of anticoagulation, contraindications like a platelet more than 25, and no active bleeding, and not known hit patient. If there is no contraindication for anticoagulation, you will send for D-dimer. If D-dimer is lower than 1, you will go with enoxaparin. Low molecular weight heparin is the preferred if we have normal kidney function. If we have impaired kidney function, creatinine clearance less than 29, you will go with heparin. But we are preferring to give low molecular weight enoxaparin if we have creatinine clearance more than 30. You can check here that we need creatinine clearance, D-dimer, and the weight of the patient. Then we will decide which dose we can start. For those patients, let's say, for example, 100 to 150, you will give enoxaparin 40 milligram Q12 hours. More than 151 kg, you will give 60 milligram Q12 hours. If there is creatinine clearance less than 29, you can give with normal weight or less than 100 kg, you will give 5,000 Q8. If very high, more than 100 kg, 7,500 Q8 hours. For those patients with high D-dimer, more than 1, okay, I will explain this one. You will contact hematologist, and creatinine clearance more than 30. As we mentioned, we prefer to use low molecular weight heparin. So enoxaparin will be started for regular weight, 40 milligram Q12 for regular weight patients. For high weight patients, 80 milligram Q12 hours, and so on. Here, the only thing I don't know if you can see that if you have a high suspicion of BE or DVT, you can start heparin infusion as therapeutic anticoagulation. Of course, after hematology and ICU consultant agreement. Thank you very much. Hello?
Thank you, Dr. Bashir.
Thank you. Thank you.
You have a question in the chat room.
The chat room.
Why oseltamivir if we are not screening H1N1?
Yes, it's recommended to exclude influenza. It's recommended to treat and exclude influenza. Unless you have confirmed COVID-19, you can also use remdesivir. But usually it's recommended to exclude the influenza with COVID-19.
Any more question? There is earliest question, I think, about remdesivir. You answered during your lecture, and there is another question about anticoagulations. You also answered during your. Yes,
Yes.
if COVID positive, we'll stop it. Yes,
Yes.
I'm agreeing for that. Yes, sure. About the oseltamivir, still the answer. If came COVID positive, we will stop oseltamivir. No more questions, Shabab. Thank you so much, Dr. Bashir.
Welcome, Dr. Ahmed. Thank you for.
Thank you.
Thank you.
Actually, thank you so much for your attendance with us on this first day. Again, I'd like to thank a lot the team of the course, all the speakers, and the two, Dr. Agul Takin and Dr. Ahmed Kohel, for great effort, as well as the coordinator of the course, Christine and Amy. Thank you so much for all of you. Inshallah, tomorrow, any study regarding 150 milligram dose? Tamiflu is still with us, Bashir?
Yes.
Any study regarding 150 milligram dose of Tamiflu? It was
For
actually
CRRT patients only. For CRRT patients, there were some regarding severe, critically ill patients, but they agreed that 75 milligram will be enough. But for those patients on CRRT, prolonged duration of CRRT, sometimes we are using the dose of 150 milligram Q12 hours. But for regular patients, even critically ill patients, we are giving 75 milligram, it will be enough.
Dr. Ala asking in the course from where we can read the topics. We will post the preliminary, our protocol, Dr. Ala, in the group now. This is including everything we are discussing, plus the lectures we are posting here and the videos, simulation videos we are posting in the groups. But the protocol almost and the algorithms we are discussing, we will post in the group to just review. Thank you, Dr. Ala, actually, for being with us and all the friends from the anesthesia.
Thank you.
We can close now and see you tomorrow, inshallah, at 10 p.m. Dr. Abar, you have Dr. Bablu, you have a question before early. Shall we unmute your mic? Dr. Bablu. I will try to unmute your mic if you have comments, because earlier you were unmute. Oh, sorry.
No, it's okay. I finished already.
Yes, boss.
No, I have one question regarding the viral load of the severity of the disease.
Excuse me?
I have one question regarding the viral load and the severity of the disease.
The Dr. Basim, I think, is not around. So
that's okay, Dr. Mahdi. Tomorrow we can.
Tomorrow we can discuss this one. I can answer, but I will keep it actually for the Dr. Basim because he's the one diagnostic. He has, and tomorrow we can reply this question for the viral load.
Okay, thank you so much.
I have a short answer for that, but not all participants are there now. But let us discuss it tomorrow.
Okay, thank you so much. Have a good night.
Thank you so much, Dr. Pablo.
Okay.
See you inshallah tomorrow. Thank you all.